probably, in my laboratory, was the first to show that we could take 90-year-old people and triple their muscle strength in 10 weeks with resistance exercise training. It was an astonishing change. We published that in the New England Journal of Medicine, got a lot of attention. The muscle that remains is extremely responsive to exercise. And the exercise that it will increase your strength and muscle size is strength training, resistance exercise.
Hello, Dr. Evans. You are a professor of medicine at Duke University, and your pioneering work established sarcopenia as a recognized medical condition. So, welcome to Modern Healthspan, and thank you so much for joining us today.
Well, thank you. I look forward to the discussion.
Thank you, Dr. Evans. So, today I would like to talk about sarcopenia, how it affects us as we age, and what we can do about it. But could we start off with a definition? What is sarcopenia?
Well, that's an interesting question that we can delve into. But when I initially defined it, it was fairly simple. It's the age-related loss of muscle, and at that time, when we first were thinking about this condition, it was our hypothesis that the loss of muscle would ultimately lead to or predict or be associated with a lot of bad things that occur when we grow older. Increased risk of disability, increased risk of falling down and breaking your hip, increased reliance on nursing homes, and even increased mortality. So that was our kind of working hypothesis, the field has been a bit murky over that time, and we can discuss why that is. But the new data that we have when we actually measure muscle mass kind of demonstrate that our hypothesis was correct, that muscle mass is maybe central to how we age. The loss of muscle mass is central to a whole host of age-related ailments that have their root cause in the loss of muscle as we grow older.
And the definition is the loss of muscle mass. It is not the loss of function that comes because of the loss of muscle mass.
Right. And we can get into the nuance of that, but we become weaker and we lose functionality, perhaps for a number of reasons that not always are associated with loss of muscle. For example, there are neurological diseases that we may have as we grow older, like Parkinson's disease, that are not necessarily related to how much muscle we have. And so we can lose function for other things, but fundamentally, the loss of muscle is always associated with some loss of function. So in order to keep the definition simple, I think, it's easier to think about sarcopenia defined as the loss of muscle. Now, the question might be, well, how do you know if you're sarcopenic? Or how does the doctor know that you're sarcopenic? And that's another question, because at the present time, your physician can't order a test to tell us how much muscle you have. So we rely on weakness, muscle weakness. And so if someone is weak, we assume that they are probably sarcopenic.
How is sarcopenia actually measured? I mean, either in the lab or in the clinic?
Well, there's been an evolution in that, and I'll just briefly take you through it. for many years, decades after the initial definition of sarcopenia as the age-related loss of muscle, investigators were using methods that measure what we call lean body mass or fat-free mass. And after decades of research, we noticed that this measurement of lean body mass was really not associated with functionality or any health-related outcomes, and led to a lot of speculation on the part of these scientists that maybe muscle mass itself, the amount of muscle that you have, is not really so important. Maybe there's other sorts of intrinsic qualities of muscle that change that we don't know what it is, but those things may lead to these outcomes. And so for many years, it was thought that muscle mass may be not so important. But the key feature is that lean body mass doesn't measure only muscle mass. It measures your total body water, the amount of water in your body. It measures viscera, your visceral organs. It measures a whole host of other things that are not muscle. And so recently, I and my collaborator have invented a new method to measure muscle mass, and it actually turns out to be an accurate measurement of muscle. And now we've measured more than 4,000 people using this method. And we find that just as we initially thought, muscle mass itself is strongly associated with strength and function and health-related outcomes. So I think we have a new way to define sarcopenia, a new way to measure how much muscle is in the human body, and hopefully it'll become a test that your doctor can order to measure how much muscle is in your body, so we can know where you stand in relationship to other people of your age.
Could you talk about how your test works?
Sure. Well, probably most of your audience have heard of creatine. And creatine is in uh, um, meat that you eat, so it's in your diet. People take creatine supplements. But fundamentally, the creatine in your body, 98% of which is in muscle. So in the human body, creatine is synthesized in the liver and the kidney. It is transported to all muscle, and that's because creatine serves an important role in generating energy for muscle contraction. So our idea was that if we could measure the amount of creatine in the body, we could then have a very, very good estimate of how much muscle is in the body, since 98% of all the creatine in your body is in muscle. So we use what's called a stable isotope method. It's called deuterium, which is kind of a heavy hydrogen. It's not radioactive at all. And we attach that to the creatine molecule, and then we give it to people in a very small tracer dose. So in an adult, the amount of, it's called deuterated creatine that we give as a capsule is about 1/20th of what might be in a hamburger, for example. It's a very, very small amount. The creatine is transported to all muscles in your body. And then the beauty of this molecule is that it's converted to a substance called creatinine, and it's excreted rapidly in the urine. So the bottom line is we give the label, a subject or patient swallows it. 2 days later, we take a single urine sample. We measure how much of this stable isotope is in the urine. and then we know exactly how much muscle you have. And now, as I said, we've put it into huge populations of older people, both men and women. There are 5 or 6 different cohort studies, including the famous Framingham study, that are using this method to measure muscle mass. We've measured it in premature infants and children. That was funded by the Bill and Melinda Gates Foundation, as they think that this method might be an excellent way to look at effects of nutritional status in children and babies. We've recently done a large study in patients with Duchenne muscular dystrophy, and we've shown that muscle mass is strongly related to their functional status. But especially in older people, we find that the traditional measures of lean body mass are unrelated to outcomes, but this measurement of muscle mass strongly related to your ability to stand up out of a chair, your ability to walk upstairs. And now that we've done large numbers of subjects, we can say unequivocally that it's associated with health-related outcomes, including a risk of disability, including what's called instrumental activities of daily living, which is an interesting one, because instrumental activities of daily living are a standard method that geriatricians look at their patients, and that includes your ability to balance your checkbook or your ability to drive or other kind of high-level cognitive tasks are also related to how much muscle you have. It's related to your risk of a hip fracture. And again, as we look more and more, it's also strongly related to risk of premature mortality. So all of the things that we thought muscle might be associated with, when we actually measure how much muscle is in an individual's body, we see that it is actually muscle that is strongly associated with these outcomes. And so it gives us hope that maybe there are a number of things that we can do to preserve how much muscle we have. And that, we hope will be the focus of the way physicians deal with muscle for their patients.
You mentioned balancing the checkbook. So this would also involve some of the metabolic effects of muscle as well as just strength. Is that correct?
Absolutely. When we think about muscle, the first thing that comes to mind is muscle gives us strength and our ability to stand up and walk around. But muscle also is what we call the primary site of glucose disposal. And what that means is that when you eat a carbohydrate meal, for example, almost all of the carbohydrate is taken up by muscle. So we have large stores of sugar, what we call glycogen or starch, but they're stored in muscle. So as we grow older, or as we grow fatter, or as we become more inactive as we grow older, muscle develops what we call resistance to insulin. And what that means is that body secretes insulin and not as much of this glucose is taken up by muscle. And this insulin resistance can lead to type 2 diabetes. And again, the primary deficit is in muscle because it's the ability of muscle to take up glucose that is impaired. And so muscle also is the primary contributor to our metabolic rates. So again, as we grow older, and as sarcopenia, which is a lifelong, or the loss of muscle is lifelong, when we become sarcopenic may be somewhat debatable, but our metabolic rate goes down. The number of calories that we use just at rest goes down significantly, and that is primarily a result of how much muscle we have. Muscle is what we call an expensive tissue. It takes a lot of ATP, a lot of energy to maintain muscle for a number of reasons. But as we grow older and lose muscle, our metabolic rate goes down. And simply what that means is our need for calories goes down. And many of us don't decrease our calorie intake to match this declining need for calories. And so one of the other hallmarks of aging is often an increase in body fatness. And that itself is then associated with a whole host of other age-related problems.
You mentioned that it wasn't clear when somebody became sarcopenic. So, is there even a theoretical definition of at what point muscle mass loss turns into sarcopenia?
That's a very, very good question. And we go back to, if you want to jump back to thinking about muscle similarly to bone. So we know that bone density goes down as we grow older. And in some women, menopause triggers an accelerated loss of bone. And the question was early on, when does that loss of bone translate to a clinical risk of a fracture? And that's what we would call osteoporosis. So, and so that is well defined and in fact expanded to include a definition of bone loss as osteopenia, not just when a person might be at risk of a bone fracture, but uh, when they when they might develop osteoporosis later on in life, and so that's treated with a host of very effective drugs. The same question has been swirling around sarcopenia. And as I said, the problem has been that lean mass itself is not associated with any of these outcomes. So it becomes very difficult then to say, well, how much lean mass do you have to lose to become sarcopenic? Well, if it's not related to strength or function or outcomes, why would it matter at all? Well, now that we can measure muscle accurately, we see um, that there is a certain level of muscle mass, and it's percent muscle mass divided by your body weight, that is strongly and powerfully associated with mobility disability. That is your ability to get up and move around. And for men, that appears to be about 25% muscle. For women, it's a little bit lower, maybe 21 or 22% muscle, below which an individual's risk of a mobility disability is extremely high. So now I think that as we generate more and more data in both men and women, we'll be able to come up with some specific thresholds whereby, um, if you're below this threshold, you might be considered sarcopenic, and then a clinician perhaps can prescribe exercise, resistance exercise, perhaps prescribe high quality protein. And as perhaps new generation of muscle drugs are being developed, perhaps maybe there'll be a pharmacologic treatment for sarcopenia.
Does the nature of muscle change with age? Does the quality go down? And if it does,
Yes,
does your test take that into account?
that's another really, really good question. So we published some papers recently in a large cohort of older men. And initially, we published a paper showing that even among obese older men, muscle mass was the primary determinant of their function and their mobility limitations. So there's been this idea, again, based on lean body mass, that there's a phenomenon called sarcopenic obesity. That is, if an individual becomes obese and then also has low muscle mass, the two things are additive and add to their risk of a functional limitation. Well, what we found is that obesity itself is not very powerful risk of disability. It's the amount of muscle, if you measure muscle accurately. But we also added a measurement in which we could measure the amount of what's called intramyocellular fat. It's an indication called myosteatosis. It's the amount of fat inside muscle. And we find that that is also independently associated with reduced function. So there are two factors, one related to the amount of muscle that you have, which is still strong, and then another one that maybe helps to define the quality of muscle, which is the amount of fat within the muscle cells themselves, and not the total amount of fat in your body, but the amount of fat that's in the muscle itself as another factor. So we would argue that unless you knew what the contribution of the amount of muscle is, the muscle mass, you would never know that there's this other feature called muscle quality that also contributes to poor function. So I think as we look at muscle with increasing scrutiny, we'll find that there are other factors that change with age. One of which, for example, is the quality of the mitochondria, the parts of the muscle cell that generate power or energy, ATP, that may also be associated with poor function. Now, all of these things may simply be associated with reduced levels of physical activity. As we grow older, most of us decrease the amount of exercise that we do. And that may be really part of this whole process, is that if we control for the amount of physical activity, perhaps many of these quality issues of muscle don't really change with advancing age. So the key, I think, for many of us in aging research is try to separate what is truly aging from kind of how we live our lives, how much food we eat and the quality of the food we eat and how physically active we are. And all of those things that tend to change as we grow older, but they don't have to change because we can do something about it.
Is it possible for anyone to request your test, like for a consumer to request your test?
Not at the present time. However, we have applied to the Food and Drug Administration in the United States to gain approval for this test as a diagnostic test. So our hope initially was that anybody could order this, but we run into regulatory issues. We don't want anyone to think that we're doing something that shouldn't be done. So when we get approval from the FDA, then I think any physician can order it. Or our hope would be even that someone could order the test online and we could send them a kit, that has the capsule and a little urine collection stick, and they would send it back in, and we could do the analysis and tell them not only how much muscle they have, but how their amount of muscle is related to people of their sex and age, and so that is our hope for the test. As I said, we also are hopeful eventually that pediatricians can use it. It's a better measure of growth, a healthy growth, than just how big a child gets. So we did a large study in infants in a neonatal ICU, and our smallest subject was 1 kilogram. So we were able to do the test in an infant, and we collected their urine just from their diaper. So it's a test that is safe and accurate at every age.
So going back to the other tests, because we can't get your
Sure.
test at the moment, which would be the best
Yes.
option. We could look at lean body mass, and would that be with DEXA? And then are there other
Yes.
methods, perhaps functional methods, that we can use to uh, uh, estimate our sarcopenic position?
Yes. I think there are a couple of functional tests that can and probably should be done by uh, um, healthcare professional. I'm not sure that DEXA itself provides a tremendous amount of information unless one is interested in bone density and risk of osteoporosis. But there's a test called the Short Physical Performance Battery, developed by investigators at the National Institute on Aging. And it's a very simple test that can be done in a doctor's office and even can be done at home. And it involves one is what is your habitual walking speed? And that's not how rapidly can you walk. It's just what is your normal walking speed, which we know is highly associated with health-related outcomes in large populations. The other part of that test is how many chair stands can you do? I mean, stand up and sit down and stand up and sit down in 10 seconds. And the third part of that test is your standing balance. What kind of balance do you have? And if you put those three together, number one, they can be easily done by a healthcare professional or an individual at home. There's a website for the short physical performance battery that people can go to. And so those sorts of tests probably will provide a clinician with as good an estimate of where their patient is in terms of functionality as any test that they can perform. Now, what's interesting to me is that most clinicians don't do the test. And we're trying to figure out why that is. And I think part of the reason is that they don't get paid for doing it. You know, a lot of physicians, at least in the US, there are payment schedules for almost every test that they do. You know, if the doctor does an EKG test, or if a doctor does a oral glucose tolerance test, or you know, one of the ones that's most frequently paid for is a colonoscopy. All of these tests to determine the health status of their patient are paid for, and so we strongly recommend that this short physical performance battery or some systematic measurement of function be reimbursed. That way, if a patient comes in to see their doctor on their annual visit, you can say, well, Mrs. Jones, your score is a little bit less than it was last year. And we should think about why that is. At the present time, there's nothing like that. Doctors don't do that. They ask, oh, Mrs. Jones, how are you feeling? Well, I'm feeling okay. All right, let's go. So they don't, you know, we don't have a means of assessing maybe one of the most fundamental changes that occurs as we grow older, and that is highly, strongly predictive of outcomes, you know, in 5, 6, 7 years in their patients. And so we would strongly recommend that these sorts of measurements be incorporated. And if they are, then even if a patient is transferred to another region and sees another doctor, the doctor can look in the patient's folder and say, "Oh, well, you're a 7 on the SPPB," and I know what that means. I know exactly what that number means. Right now, we have no way of doing that for patients. So some systematic way of examining functionality in older patients in particular, I think is you know of great importance.
Would the test be something that you could do at home?
Yes, it is. you know that it is absolutely a test that you can do at home. And in fact, there is for some and clinicians that do large population studies where the patient doesn't necessarily come into a clinic, they can do it online or over the phone. So there are a lot of ways of getting this test done. And there are also even uh, well-regarded questionnaires that have been validated where, you know, a doctor can ask their patients specifically about functionality. But again, they're not typically done in a doctor's office. And there's been no systematic effort to try to include these tests in a normal um, examination. In fact, habitual walking speed has been called the vital sign that should be measured in all patients. You know, it's as important a predictor of outcome as blood pressure, for example. So, you know, I think we still go a long way. I think one of the maybe root causes that we've discussed in some of the papers that I've written is that many people and many clinicians think that sarcopenia is an inevitable consequence of aging. And so at some point as we grow older, we're all going to become sarcopenic. So, you know, so what? So maybe there's not much we can do about it. But that's not true. You know, the people that become sarcopenic, that is, have a low enough muscle mass that it may result in a mobility disability, that's only 15%, maybe 20% of the aging population. So it's still substantial, but it's still a relatively small percentage of the total number of people that are out there. So I think you know, if we do more to prevent sarcopenia, then the percentage of people with sarcopenia may ultimately go down.
Could we go into a bit more detail on your thoughts of whether the reduction in muscle mass is because we're getting older, or is because of changes in behavior, or is there some third reason?
Well, I think there are a number of potential reasons for sarcopenia. Um, and I mean, the big two are aging. We know that aging is associated with loss of muscle. And, you know, for example, muscle cells are part of what's called a motor unit. That is, muscles are directly connected to the brain. So when you move your arm, for example, your brain is recruiting motor units, and one motor unit might be a motor nerve that's connected to multiple muscle cells. We lose motor units as we grow older for reasons that are not terribly well understood. But the total number of muscle cells that we have goes down with advancing age. And there may not be a whole lot that we can do about that. It's still not well understood why that might be, and there may be other treatments to limit that, but it seems to occur with advancing age, and it seems to affect what are called the fast fibers, the fast twitch fibers. So our bodies, to get into the physiology and metabolism a little bit, our bodies have two main types of muscle cells, what are called fast twitch and slow twitch, what other people may look at as red and white fibers. They have different metabolic qualities. For example, if you've eaten breast muscle from a duck, you know that the breast muscle from a duck is very dark and oily. And that's a reflection of the metabolic qualities of a duck that can fly for thousands of miles without becoming fatigued. And that's the so-called red or slow muscles. You know, the breast muscle of a chicken, for example, is white. And a chicken is not known for its endurance qualities. It can maybe fly from a floor to a tabletop. And those are the so-called fast fibers. and our bodies have both of those. The fast fibers contract with greater force and provide more strength. And as we grow older, we lose fast fibers preferentially. Again, that seems to be an inevitable consequence of aging. But we also become less physically active as we grow older. That also results in some loss of muscle. And there are periods of time where a person may become ill and forced to go to a hospital for treatments, or may become ill and forced to go to bed for a while to recover. And we know that bed rest itself is associated with an incredibly rapid loss of muscle. My laboratory did some studies where we put healthy older people to bed for just 10 days to look at what happens to their metabolism. And we see that these healthy older people lose 3 times as much muscle uh, in a third the period of time as young people do when they're put to bed for the same amount of time, for even longer periods. So there's something about aging that causes a more rapid loss of muscle when we're inactive. And that probably is related to this feature that I was talking about earlier called insulin resistance. Insulin resistance itself in muscle leads to a reduced efficiency of making new protein in muscle, protein synthesis rates. Bed rest is associated with a almost 40% reduction in the rate of muscle protein synthesis. So bed rest, loss of muscle is fundamentally due to a great decrease in how many new muscle proteins we're making. So there are a lot of factors here, but the big three are aging, physical activity, and one of which could be inactivity. And then another one that we really haven't talked about very much, but diet. One of the other things that we've noticed as we grow older is that we require more protein in our diet to maintain our muscle mass than do young people. So dietary protein requirements go up as we grow older, even though the amount of muscle we have goes down. And there are reasons for that. The other things that we haven't discussed that affect muscle mass is, for example, in men, testosterone levels go down, testosterone production goes down. Growth hormone production also goes down with advancing age. These are the two main so-called anabolic hormones that help to maintain protein synthesis. And in women, estrogen levels go down, which are also associated with accelerated loss of muscle. So again, those we ascribe to aging. You know, the treatment for low testosterone is giving men testosterone back. You know, there's no lifestyle changes that will increase testosterone levels.
So if we want to maintain our muscle mass, what options do we have? Let's start off with lifestyle options. Is resistance training the only thing?
There are two things. Probably in my laboratory was the first to show that we could take 90-year-old people and triple their muscle strength in 10 weeks with resistance exercise training. It was an astonishing change. We published that in the New England Journal of Medicine, got a lot of attention. The muscle that remains is extremely responsive to exercise. And the exercise that it will increase your strength and muscle size is strength training, resistance exercise. So we put these men and women on a strength training study in a nursing home in the Boston area. In 10 weeks, they were walking faster. They could climb stairs more easily. And as I said, they tripled their strength. And the other interesting feature, we had what we call an attention control group, a number of people who were not doing resistance exercise, but they were playing games and other things that would get them out of their rooms and moving around. But it was only the subjects who did strength training that we saw a real noticeable decrease in depression. So the resistance exercise really was associated with more than just functionality, but also how they felt about themselves. And it all maybe all is related. They they told us, they no longer needed to ring for a nurse in the middle of the night to use the toilet, or they could get up and go get their meals rather than having it delivered. So for now, perhaps the best and most effective way of increasing strength and muscle mass is through resistance exercise training. The other one is a careful adherence to a diet that is rich in high quality protein. And I think that that's one way, if an older person is eating a protein deficient diet, then increasing protein intake has been shown to increase the amount of muscle you have. But it can certainly help maintain the amount of muscle you have without losing muscle. And as you may know, there's a whole new generation of so-called weight loss drugs, the so-called GLP-1 drugs that are taking the world and medicine by storm. Um, and they do lead to weight loss, in some cases, a great deal of weight loss. And there is a great concern on the part of the companies that have these drugs that the weight loss is associated also with a loss of muscle. And I'm most concerned about the obese older people that are taking these drugs because I think they'll lose muscle um, and perhaps not gain it back when they stabilize their body weight. So I'm concerned that older people who are on these kind of weight loss drugs, unless they're engaged in some sort of physical activity, and also perhaps using a high quality protein supplement to maintain protein synthesis in their muscle, that they'll lose an accelerated amount of muscle during their weight loss. So I'm not as concerned about young people because I think they may gain whatever muscle they've lost back. But the evidence is that once an older person loses muscle through weight loss, they don't really gain it back.
And how much protein would be, yeah, how would you measure a high protein or a sufficient protein diet?
Sure. Um, most so if we take a average 70-year-old person, man or women, they're consuming maybe 1,700 to 1,800 calories a day, about 15% of which is protein. So already they're eating a lower protein amount than younger people just because their total calorie intake is lower. Um, and so, it, you know, the recommended dietary allowance to maintain balance is about 0.8 grams of protein per kilogram body weight per day. As I said, many older people are either at that level or below. What we find is that many older people need more protein than that. So we can maybe assume that most 70-year-old people, unless they're eating lots of food, are eating a slightly protein deficient diet. So what our recommendation is to try to focus on high quality protein foods, fish, for example, low fat foods, because we don't need the fat. So just a simple shift in your protein intake can really have a tremendous influence. And then, if need be, there are inexpensive protein supplements. Whey protein, for example, is a protein that's rich in what are called essential amino acids, the amino acids that we need to help make new protein. So, a diet that has some amount of high quality protein, or a supplement that has high quality protein that contains all essential amino acids would be of some benefit. If one is a vegetarian, soy protein, for example, has all essential amino acids, so it's also a high quality protein.
Does this decrease in muscle affect men and women the same?
Well, we're just looking at that. That again is a question that has not been answered sufficiently. And we're just actually looking at those data. So we have two large cohorts. These are large epidemiological studies, one of which is called the Mr. Oss study, a study funded by the National Institute of Health to examine osteoporotic risk factors in men. So we have a large population. We've measured muscle mass in men. And now we have the same sort of study in what's called the Women's Healthcare Initiative, WHI, which measures only women. And so I was just looking at brand new data in about 2,800 women, old women, and what we're seeing is very, very similar to that of men. That is, when muscle is strongly associated with how well they move around and how their functionality. Whether or not the threshold for sarcopenia or low muscle mass as predictive of a mobility disability or other problems will be the same is unclear, but it is likely that women can sustain maybe a lower muscle mass than men without having a functionality problem. As I said earlier, it looks like for men, the threshold may be 25 to 27% muscle that leads to a high risk of a mobility disability. For women, it may be 21 to 23% muscle. So small differences. We're just exploring those right now, but clearly men and women maybe sustain their functionality maybe in slightly different ways, and we're just exploring that now. So I think that we will find that men and women are different in how they deal with lower muscle mass and the accommodations that they may make.
Earlier, you mentioned hormones and how important they were. So, could we just go
Yeah.
into that in a bit more detail? Would you recommend hormone replacement therapy as a way to help maintain muscle mass?
Well, that's a difficult thing to say. That there have been studies kind of looking at that. One of which is the use of growth hormone. So there were a couple of studies, maybe 30 or 40 years ago, that showed that growth hormone administration to older people improved their lean mass, improved functionality to some extent, but also improved other factors associated with aging, like skin biology. Led to a large number of studies specifically looking at growth hormone. So again, human growth hormone is secreted by the pituitary, and it's secreted in short bursts. It's not like just it dumps out a whole bunch of growth hormone. It's secreted in short bursts. And the growth hormone studies were using kind of injections of growth hormone. And while it had some positive effects, it also had a lot of very negative effects. One of the features that growth hormone may result in insulin resistance and increased risk of diabetes. It also led to carpal tunnel syndrome and other side effects that kind of led to not really thinking about growth hormone administration. And then there were a number of new drugs that came out that were called growth hormone secretagogues. These were molecules. There's a hormone called ghrelin that's secreted by the stomach that stimulates the production of growth hormone. And the thought was that these growth hormone secretagogues would be, again, used to improve functionality in older people. And again, they have that effect, but even using a growth hormone secretagogue, there's an increased risk of developing diabetes. So those drugs have been kind of put off the shelf. The other one that is really available only to men is testosterone. And testosterone is used only if a man is what's called hypogonadal, if they have low testosterone levels. And there may be some positive effects of increasing testosterone levels, but it's more difficult because testosterone comes as kind of a stab or gel that you have to put on your skin, so the testosterone can be absorbed. And if your wife or partner, touches your skin, they can absorb it as well. So there's some problems with testosterone. So there is, I can tell you, a whole new generation of muscle agents that are being developed by biotechs and pharma to maybe affect muscle mass in a safe way. And remember, one of the other ways that we lose muscle is if we become really sick. So cancer, there's a condition called cachexia, which is very specifically the loss of muscle that's associated with a chronic disease. So cancer, we know, is associated with rapid loss of muscle. Heart failure is associated with low muscle mass. Chronic obstructive pulmonary disease is also associated with low muscle mass. And so many pharma companies are trying to develop treatments for these diseases specifically related to muscle. So I'm hopeful in the next few years that we'll have a safe and effective drug to affect muscle. But really right now, hormone treatment is not really thought of as a way to increase muscle mass or prevent sarcopenia because of the side effects of hormone treatment, including estrogen. Estrogen hormone replacement therapy has really kind of been reduced in popularity and importance because, again, of the side effect profile.
If I exercise, right, it sends a message to my muscles to grow.
Yes.
So is the
Yes.
idea that these pills that are being developed would just basically mimic that message so that I would then grow the same muscle, but I wouldn't have to do the exercise?
Yes. To put it bluntly, that's the hope that there's a medicine that will work like exercise. And and there are some features of exercise that, in fact, can be reproduced, perhaps, but not all of them. For example, there's a new a drug, a new sort of peptide or hormone that just been kind of described in the last 10 or 15 years called apelin. Apelin is a protein that's secreted by muscle during exercise, and this molecule has a number of really positive effects. It increases insulin sensitivity and maybe can be a way to prevent diabetes. It appears to have positive effects on muscle protein synthesis. And so there are a number of biotechs that are developing this potentially as a treatment for preventing muscle loss. But the thing about exercise is it doesn't just have one effect. It essentially affects every single system in the body. It really is quite astonishing. There are things that exercise do that you wouldn't necessarily think would have any effect on, reproductive capacity or cognitive function or risk of colon cancer or, a whole host of other factors that you may not necessarily say, well, that's caused by exercise or lack of exercise. I mean, the things that we do know that exercise does decreases risk of diabetes, increases energy expenditure, and helps for weight loss, increases your functionality. Those are all well known, but it's the really all of the other effects that what's interesting is that the single most important thing that you can do to prevent Alzheimer's disease is exercise. Walking 3 days a week, just walking 3 days a week has a significant effect on prevention of Alzheimer's disease in large kind of cohort studies. So again, while we may isolate the effects of exercise in a single peptide or protein or hormone, and in fact that's going on right now, it's the widespread effects that are going on. There's a big 50-60 million dollar study being funded by the National Institutes on Aging, specifically to look at the effects of exercise on every system in the body. And the biotechs and drug companies are kind of engaged in that because they're looking at what things change in the bloodstream that we can measure that are associated with exercise, and do these things that change, are they associated with some positive outcome? So it's a complicated analysis, but as I said, almost everything changes in the body with physical activity.
Yeah, so it certainly looks like we're not going to get out of exercise anytime soon, which is fine because I like exercise and I think.
Yeah, I think that's true. And in fact, it may well be there are that if we have a drug, for example, that we think has positive effects on muscle, it is highly likely that that drug is going to be way more effective in a person that's physically active than a person who's not physically active for a lot of reasons. One of which is that you get increased blood flow with exercise to the working muscles. Um, there are and just moving the muscle contraction itself may potentiate the effects of these drugs on the synthesis of new proteins in mitochondria and the contractile components of muscle. So that it's I think we can't escape the fact that exercise and physical activity it maybe is fundamental to kind of how we age, and that if we come up with any sort of anti-aging drug or effect, it will almost certainly be potentiated or improved with physical activity.
It would certainly be helpful to have a drug that would help with this, the decrease in your ability to build muscle as you get older, even though you exercise. So if you could just get back to normal, that would be
That's
very
right.
helpful.
That's right. And in large, again, if we look at men who have been weightlifting for most of their lives, their muscle mass is the same as a 20-year-old. Okay. not a 20-year-old who's been resistance exercise training, but it is clear that that resistance exercise itself will preserve muscle and keep it kind of youthful. Um, Running sorts of exercise, aerobic exercise, does not appear to prevent the loss of muscle by very much, maybe a little bit. But we know that is that runners themselves don't look like they have a lot of muscle. If you look at marathon runners, they have extremely high quality muscle, but they're pretty lean. They're pretty small. Whereas someone who lifts weights, has a body type that looks completely different. So, that obviously different kinds of exercise have positive effects. Both kinds of exercise, both resistance and aerobic exercise, are associated with increased longevity for sure.
Yes, you have to do both, really. You have to work on both if you for health span.
Yeah, that's right.
Okay, excellent. Dr. Evans, thank you so much. So, where can people go to follow your work?
Um, uh, it's a good question. Our company has a website now. We've formed a new company to try to get this test approved by the FDA. Our company is called MyoCore, MYOCORPS, and we have a website, www.myocore.com, where we've listed all of our publications that are associated with this method and muscle and how it is associated with functionality in older people as well as in patients with Duchenne muscular dystrophy and infants and children. So you can check that out if you want.
Excellent. Yes, that would be very good. Do you have any idea of what kind of time scale the regulation is going to take?
Probably another 2 years. My guess is the FDA works slowly. They're going to require that we do a clinical study to demonstrate that this is a test that we think that it is, even though we've published now almost 30 papers in more than 4,000 people. It has to be done under FDA regulatory supervision. So we understand that, and so we're just raising some money right now to do the clinical study.
Okay, excellent. Well, I definitely look forward to that. It will be great to have a better way to measure. I mean, yeah, I did a DEXA scan, and the results were very unclear. What it actually when I actually got the
Yeah,
results, it wasn't clear what they meant.
right. The beauty of this method is that it only requires a single urine sample. So it's completely and totally non-invasive. So it allows us to do this test on virtually any population. We've even done a study in malnourished children in Bangladesh, for example. So we can do it sort of in any population. So anyway, so yeah, so keep an eye out and go to MyoCore.
Okay, I will do that. So, Dr. Evans, thank you so much for joining us today.
Oh, you're very welcome. Thank you.